Hi everyone, this is Brian Shapiro and hope everyone's doing well. And today we are going to do in the next session the pathology of melanocytic lesions. So this is something you could spend 10 years doing, and we're going to do it in one session. It's a very controversial area of pathology, probably the most controversial of all. There's been some interesting new data. And I thought instead of going systematically through all the different types of nevi and melanomas, which people basically know quite well, I would just go through some of the newer stuff and a potpourri of kind of cases and see if we can approach it that way. So I first put together a little PowerPoint of some of the new data. So melanocytic pathology is definitely one of the most controversial areas of all pathology, and there's been a lot of interesting literature on overdiagnosis and some on underdiagnosis, and this is one article from Earl Glusack, The Melanoma Epidemic, Lessons from Prostate Cancer, and they've compared prostate cancer's increase in the differences in diagnostic criteria, and also thyroid cancer, papillary carcinoma of the thyroid, and spoken about diagnostic creep in melanoma. Here's the article, and I will send this out, and this speaks a bit about the overdiagnosis in melanoma histologically, and this was quite a few years ago already, and 2012, I think. Then in 2003, this is even further, there was under the microscope, doctors, lawyers, and melanocytic neoplasms, and this is an article all about how these lead to often medico-legal issues, and also which I'll send out. So some of these articles speak about the tissue, and this is an interesting approach. It says, can you imagine a fine needle aspiration of a Spitz nevus or a nevoid melanoma? In both cases, there would be a high likelihood of misdiagnosis. So no one would obviously recommend doing a fine needle to find this. But when we look at small or partial biopsies, which are frequently performed for melanocytic lesions, we don't really have the same feeling that this is inadequate to make a diagnosis. The partial biopsy assumption is that the clinician can consistently predict what portion of the pigmented lesion will have the worst histologic features. And this is proven wrong on many occasions. So the tissue is the issue, is a kind of interesting approach. The next thing is that experts disagree frequently. And the difficulty that we face with these melanocytic pathology is the fact that for virtually every difficult melanocytic lesion we look at, there's conflicting histologic criteria. For instance, you may have circumscription and maturation with or without mitotic activity, or there may be single cell solar elastosis and asymmetry. And you don't find all these criteria in all biopsies. And there's no literature which tells you how to accurately diagnose most melanocytic neoplasms which have conflicting criteria. So say it's well circumscribed, but it's in sun-damaged skin, or it matures, but there is mitotic activity. And so balancing what Glusack says is at least a dozen different criteria comes down to a refined instinct and judgment. So that's part of the pathology. Now, very recently in the New England Journal, there has been a sounding board on the rapid rise of cutaneous melanoma diagnosis. And this is out of the East Coast, from, I think, Boston and New Hampshire. And they have looked at the rapid rise of melanoma diagnoses and tried to tease out what is the cause of this. And when you look at their article, you'll see that the incidence of melanoma has risen dramatically, but the mortality is basically flat. So either we have got really fantastic new treatments, which we do, but these only came in the mid-2000s, and if you look, the increase has been starting since 75, or there's been what they call diagnostic creep. And we also now look at the amount of skin biopsying going on. And if you look at Medicare beneficiaries from 2004 to 2017, this is the incidence of skin biopsies, they are just going up dramatically. Okay. And with that incidence of increased doing of biopsies, you are also seeing increased diagnoses of melanoma. So the question is, are these melanomas, which are melanomas pathologically, but they are biologically insignificant, much like the papillary thyroid business, or what else is going on? And then they also looked at diagnoses, how they've changed from 2004, and I'll send this article out as well. And if they took cases from 2004, which were diagnosed as melanoma or benign, and then re-looked at them, often with the same people, they found that many of them were upgraded from benign to melanoma when the slides were looked at 10 or 15 years later, whereas very few were downgraded. So again, you've got this problem that there's diagnostic creep. So the article goes on to describe a cycle of melanoma overdiagnosis, where there's heightened awareness because you have Melanoma Mondays, you have melanoma survivors, there's more talk about it. So the population then seeks evaluation that leads to lower threshold to biopsy, many more biopsies being done, and many more primary cares referring for biopsy. Then you have dermatopathologists in the mix who lower the threshold to diagnosis, which then leads to more melanomas, which leads to apparent improvement of outcome because higher 5-year survivals, and an apparent epidemic, which then again feeds into the heightened awareness. And so you have this cycle of melanoma diagnosis, and the mortality is not increasing. So this figure I showed you was the pathologic threshold for melanoma. This was 9 dermatopathologists looking at 40 skin biopsies 2 decades earlier, originally benign and some originally melanoma, and then what they would be diagnosing them 2 decades on, 20 years on. And you can see with 20 years later, a lot of these were upgraded to melanoma. So that's the diagnostic creep we speak about. So this article says it's not the UV exposure, it's diagnostic scrutiny. So I'm then going to go into a recent article on a practical approach to the diagnosis of melanocytic lesions, which I think is really useful, and I'll send this around as well. So the first thing is to look at clues from the requisition. And this is the age of the patient, the site, the size of the lesion, and the clinical suspicion. Now, often we get the age and the site, but the size and the clinical suspicion, it comes rule out atypical melanocytic process. So those are 2 really critical pieces of information, which if you don't have, you can get into trouble. Then the clues from the low power diagnosis is the 4 S's with a little bit of liberty to make circumscription an S. And it's symmetry, circumscription, size, and sun damage. And if you have a partial biopsy of the S's, the symmetry, circumscription, you can't evaluate. The size, if you don't have from the clinical requisition or a picture, you can't evaluate. So in all these clues, if we are dealing with partial biopsies and not a clinical size, we can only evaluate sun damage. Then from high power, you know these well, the growth pattern, the junctional melanocytes, whether they're single or nested, growth down the appendages, pagetoid growth pattern, epidermal consumption, dermal expansile nodules, and I'll show you all of these. So that's the architectural features. And then the cytologic features, which are enlarged nuclei, hyperchromatic nuclei, dusty melanin pigment, and mitoses. So this is a real good basic approach to how to do these melanocytics. So let's start by looking at malignant features in benign lesions. And the problems here are a disordered junctional growth pattern in recurrent nevus. So if you see a scar, and I'll show some examples, you need to understand that there's a so-called pseudomelanoma that Ackerman called. Mitoses in the dermis, which you can see in pregnancy. Pagetoid spitz nevus, where there's upward growth, but it's a pagetoid spitz. Nevi of special sites, and I'll go into these, and these special sites keep expanding: scalp, acral, genital, milk line, umbilicus, popliteal. and then deep penetrating nevus, which is also histologically can be fairly alarming. And then what really makes us not sleep at night is benign features in melanoma. In metastatic melanoma, you can see blue nevus-like features histologically with just melanophages and lymphocytes, and can look pretty banal without these big atypical melanocytes in the dermis. The big one, desmoplastic melanoma, where it looks like a scar or some fibrosis. And this is helped with the mpox, negative with melon A and HMB45, positive with S100 and SOX10. The important nevoid melanoma, which at low power looks like it's maturing and it's a dermal process, and Phil McKee famously called this a melanoma you diagnosed as a nevus but wished you hadn't. Consumption of the epidermis and stuffed papillary dermis with deep mitoses are clues to nevoid melanoma. And then the perennial problem of the spitzoid melanoma, and I'll show some features of those. So I went through the lesions that are benign but can look like melanoma, then the lesions that are malignant but can look benign, and then in the middle are these problematic lesions. First is the dysplastic nevus versus melanoma, again a perennial problem. And one of the clues here is beware of a dysplastic nevus of the face or one where there's marked solar elastosis. Second one is malignant blue nevus, often with overlapping with the desmoplastic melanoma. And then this big group of spitzoid lesions, which some can have lymph node deposits and absolutely no progression. And this is atypical Spitz tumor, atypical Spitz nevus. And here genomics is really starting to help. And I'll show some pictures of that. And then this lentigo maligna versus the atypical junctional proliferation versus actinic melanocytosis. So these patients with sun damage get so-called actinic melanocytosis, which is a field defect, and you have increased melanocyte numbers in the sun-damaged areas. And then distinguishing that between that and atypical proliferation and lentigo maligna is a real problem. There are studies doing counts of melanocytes, and there was some immunohistochemical, cyclic adenylized phosphate, which didn't pan out, I don't think. So this is a perennial problem. And again, this differential between atypical junctional proliferation and lentigo maligna, where exactly you pull the trigger, is not reproducible at all. Immunohistochemistry and genomics to the rescue. So this is an evolving field. Some tips: if you have a diagnostically challenging lesion and you're going to do studies for immunohistochemistry, cut unstained slides, because there's all kinds of new studies that come out. In the future, studies might come out. So having unstained slides means that you don't waste the tissue. The gradient with HMB45, where in benign lesions, the dermal component HMB45 is supposed to peter out towards the base of the lesion, is fairly useful in maybe nevoid melanomas, but not useful in many of the Spitz nevi, which are the problematic areas, or atypical Spitz tumors and blue nevi. Looking for proliferative activity, if you can't find mitoses, you can use MIB1 and PHH3, or MIB1 and T67, and this can look for proliferative activity. And then more recently, there's PRAME, BAP1, P16, and I'll go into some of these, and SOX10. SOX10 just is a good stain for melanocytes and stains spindled melanocytes. The PRAME is a melanoma-specific antigen and has been fairly useful, but in my experience, it's useful in the slam dunk cases where we know it's melanoma. And in these borderline cases, PRAME can be problematic. BAP1 is a group of epithelioid lesions, BAPomas, which are now called BAP inactivated melanocytic tumors. Most of these are benign, but again, they are BAP1 deficient melanomas, so it's not an all or nothing. And P16 preservation in spitzoid lesion is something that is comforting and speaks against a melanoma. Genomics to the rescue. The first genomics that was commercially done was the 6-probe fish study, which is still in use. And then comparative genomic hybridization, which is a tricky technique and which can be useful, but has to be done at specialized centers. And this is a very good review of the classification of melanomas with the subtypes by comparative genomic hybridization. I'll send this one out as well. This is basically a reference article. It's just showing how melanocytic lesions are evolving. So that's a little overview of approach to melanocytic lesions, and I will now show some slides. So this is the first one. This is in no particular order. I've just put together a potpourri of melanocytic lesions to give you a kind of feel of where we are with these. So the first one, this is a beautiful, looks like excisional biopsy, lesion dead center. There's relatively normal epidermis at low power. Not much sun damage. So this is the kind of lesion you can assess: symmetry, circumscription, sun damage, all the S's that you need to. So we see a dermal process predominantly, and it's nested all the way along here. Fairly symmetric. If you divide this into it, you'll see it fairly symmetric. And it's comprised of nests and fascicles of kind of spindled cells which dissect through the dermal collagen. There's no mitotic activity. The cells have oval nuclei, distinct nucleoli, pink cytoplasm, and each cell looks the same. And when we look at the epidermis, there's really no epidermal involvement. Now, some of these cells are spitzoid. They are epithelioid. They're enlarged. They're quite a lot bigger than the spinous layer keratinocyte. Oval nucleus, distinct nucleolus, pink cytoplasm. And these fascicles kind of interweave. There's no caminobodies. There's no epidermal hyperplasia in this case. And the patient was a youngish patient. It's out. So I think this is in the department of Spitz nevus, or dermal Spitz nevus. And getting back to the genomics and immunohistochemistry, these are now divided into these deletion Spitz nevi with all kinds of different deletions. And this one happens to be one with a ROS1 deletion. And this is staining for the ROS1 deletion. And you can see these cells stain. So the Spitz nevi now are getting divided based on genomics, and they're a complicated set of the genomics, but these Spitz nevi with the different deletions, and you can check for those. Okay, the next case is this. So in contrast to the previous case, we now have a shave biopsy with a lesion extending to the bottom. You can see there is probably a little bit of sun damage here. It's somewhere on the face or head and neck because you're seeing these big sebaceous glands. It's irregularly pigmented. You can see pigment here, and this is dermal expansile nests without good maturation. And when you look at these cells, they look similar to the previous one, but it's not as well organized. Oval nuclei, small nucleoli. No real intraepidermal involvement. Big expansile nodules. And I'm looking for some mitotic activity. This is one you might do PHH3, key 67 to look for proliferative activity. And there's really no maturation of the cytology. The cells here deep down look exactly the same as the cells high up. It's transected at the base. It's a little asymmetric. This piece is not quite exactly like this. There's no intraepidermal upward growth. And this then would fall into this rubric of the atypical Spitz tumor and need further workup. And Spitzoid melanoma versus atypical Spitz tumor, and these are always tricky cases. And this is a case you might send for genomics to look at exactly what the chromosomal abnormalities, comparative genomic hybridization. Kind of get a sense of what's going on here. Obviously, we have to be re-excised, but the problem is this is probably much more than a millimeter, so this would fit for a sentinel node. And then with these spitzoid things, if it's a sentinel node positive, that doesn't often predict the prognosis of the patient like a conventional melanoma sentinel node, because as I said, there's this group of, especially in children, spitz nevi and spitzoid, atypical spitz tumors that have positive node deposits, but don't progress to advanced disease and see much epidermal involvement. So this is a problem, and if you send this to different dermatopathologists, you'd get different ways of reporting this case, and Doctors Barnhill and company are now devising this empath system, where they're trying to say, despite our differences in how we report these cases, we should have an empath treatment treatment rubric, or a treatment algorithm, that they all at least get treated the same. Okay, so the next we're staying on the same kind of theme, and here we have a nice, looks like maybe a sulfurization or maybe a deep punch of a dermal process, and you can see there's thinning of the epidermis even at low power, and it looks relatively symmetric, doesn't look like a lot of sun damage, and looks predominantly nested. And here we start seeing each nest looks the same. There's some cracking artifact of the nests, and the nests are comprised of spindled and epithelioid cells. You can see the spindled cells, you can see the epithelioid cells. It's mainly nested. There's some upward growth. Here's a melanocyte going into the granular layer. And when we look over here, the nests are at the tips of the rete ridges and moving up the rete ridges. It's associated with a dense lymphoid infiltrate, which is patchy. When we look at the cells here, oval, nuclei, distinct nucleoli. And here at the edge, we start looking more like a dysplastic nevus, because you've got some bridging of nests with some lamellar fibroplasia and pink going around. Here's some upward growth again, but not really a lot. And here you've got bridging of nests again, see, like Dr. Clark's dysplastic nevus. So we could spend the whole session just on this lesion and looking at things, but you obviously look for sun damage, you look for deep mitoses, which I'm not seeing here. And this has got a shoulder, because you can see here's the dermal component, and the shoulder to the edge is like the intraepidermal, just like a dysplastic nevus. So these now are falling into the in-between. It's got features of a dysplastic nevus and features of a spitz nevus. And we don't know the age in this one. I think this stain was a melan A stain. This just highlights the melanocytes. And these in-between lesions have gone under a lot of names: dysplastic spitz, DITS, nevus, and I think it doesn't really matter what you call them. I usually get them excised, because we'd like, just with spitz nevi, especially in adults, we'd like to have them completely removed. But here you can see the architectural features of a dysplastic and the cytology of the spitz. Okay, the next case is a little variation of the theme. Here again is a nice biopsy with a whole lesion included, a compound lesion with mainly nests in the intraepidermal component, with these parallel arranged melanocytes with granular cytoplasmic pigment, a little bit of epidermal hyperplasia. Some of these cells are a little epithelioid, almost a Camino body, and each field looks the same, a little cracking artifact. In the dermis, similar cells with heavily pigmented melanophages. And this one also has a specific genomic alteration. And this is a pigmented spindle cell nevus of Reed. So this is one that comes up on the boards. Often, these are often darkly pigmented, very clear clinically. You can see them any site. I've seen them on the face. You can see them on the thigh and extremities. And this is a PSCN. And what's helpful here is it's the same look from field to field. So even though there is some upward growth, now you've got to be careful with upward growth, because upward growth within the rete is not real upward growth. So when you want to use pagetoid spread as a sign of a melanoma, you really have to start seeing it in the granular layer. But this is a beautiful pigmented spindle cell nevus of Reed. Okay, the next case. So this is one of the ones that you worry about melanoma, but it turns out to be benign. So we see a pandermal process with nests and fascicles of heavily pigmented cells extending into and dissecting through the panniculus. Here you can see the fat. And these cells are going all the way into it. No real epidermal change, a little bit of atrophy maybe, and no real epidermal component. And here you can see again the cells are spindled with fine chromatin, small nucleoli, pink, unremarkable cytoplasm, and they're associated with these heavily pigmented melanophages. And when you look on low power, it's got a wedge shape. And often these fascicles go around the appendigeal structures and it goes deep. And this is a classic deep penetrating nevus. So these fascicles of melanocytes associated with clusters of melanophages, wedge shape going down the follicular structures, is a DPN. And these ones you look for mitotic figures, for areas of necrosis, which I'm not seeing here. And just as an aside, often combined nevi have a DPN-like part. So you have combined deep penetrating and blue, or deep penetrating and congenital. And so this component can be seen in a combined nevus, which is important to know. So here things start getting a little trickier. This is another case where again you can see this wedge shape and going down, probably here's the smooth muscle, so it's probably going down the follicle, and it's a heavily pigmented lesion. Comprised mainly of melanophages, and when you look in the, I can't get higher than this, but when you look, there are also kind of epithelioid melanocytes. And this has been called pigmented epithelioid melanocytoma. And these, again, a group of these are BAP1 deficient, and it gets kind of complicated, but some people say these, have got some similarities to deep penetrating nevus, but I think they're different because you see much more melanophages and much fewer of these fascicles of epithelioid and spindle melanocytes. And you often have to bleach these to kind of look for mitotic activity and look for the cytology of these cells to see it's not just a heavily pigmented melanoma. So interesting, all the slides I've shown you up till now, you can see beautiful biopsies where the whole lesion is taken out, which makes it really easy. But in real life, this often is not like that. This is just another one of these deep penetrating nevi, so you can get a feel because I like these on boards. The wedge shape, some epidermal atrophy, maybe dome-shaped lesion clinically, relatively symmetric, fascicles of these melanocytes with elongated nuclei, unremarkable chromatin, together with these heavily pigmented melanophages and tracking down the follicle over here. Okay, so now we come to a little more of what we see day to day. Shaved biopsy, sun-damaged skin, chipped off. So we can't evaluate symmetry. We can't evaluate circumscription. We've got sun damage. And the size of the lesion, we don't know. We may know from the clinical. But when you low power this, you already are in trouble, because you start seeing these nests of melanocytes. There's atrophy. They don't have the reachy ridges here. And they're growing confluently, going a little bit down the follicle, and it's asymmetric. They're growing there, then they've disappeared, and they're growing again. And when you look, these melanocytes are hyperchromatic, dark blue nuclei. There's some that are growing up. There's a lot of sun damage, single cells, beautifully tracking down the follicular epithelium. This is not a nevus. When these single hyperchromatic melanocytes grow down the epithelium like that. And then there's some in the dermis. Here, and the dermal cells look exactly the same as the intraepidermal ones. So this is lentigo maligna melanoma. You can see here beautifully growing at the dermoepidermal junction with upward growth and completely disordered growth. And if this extends down here, so this you can't get an accurate Breslow depth because it's a minimum, I think. These expansile nests in the dermis without maturation. And often you can find mitotic figures there. So this is a beautiful stain as well of a classic melanoma in sun-damaged skin. And I think here was a SOX 10 stain, which is a very clean stain. And often these are just done to evaluate the depth. But as you can see, if you have these nests deep down, chipped off at the bottom of the shave, the depth is a minimum. And this is a really beautiful stain. See the nests going up into the epidermis. So that was the one kind of melanoma over here. Now we see another process, a dermal process, again, a deep shave. Looks like an adult with quite a lot of sun damage over here. See the elastotic fibers. And a big dermal nodule. And there's irregular pigment here, no pigment here. And this nodule is comprised of big atypical cells, hyperchromatic cells, different shapes. Here's an elongated one, here's a round one, different sizes, small ones, bigger ones, irregular melanophages, and then intraepidermal. You can see them growing along the dermoepidermal junction with no real nesting, just single cells. So this is a melanoma, and if you don't have 3 reachy ridges involved at the edge, it would be a nodular melanoma. Now be careful, you need the history here, because this could also be an epidermotropic metastasis. So you really need to know the history. And I'm not going to spend a lot of time here, but in these cases, you often find mitoses, and there's obviously no maturation. And when you're looking at these, look for perineural invasion and look for intravascular invasion. You look at these dilated vessels here to see there's no tumor, because those upstage the intravascular will upstage the staging, the pathologic staging of the melanoma. This patient needs a sentinel node. It's going to be more than 1 millimeter. And this is an ugly melanoma. The lymphocytes don't like it. You can see these patchy lymphoid infiltrate. And I think no one would have a problem with this one. Here's a similar case, nice shave, excision it looks like, epidermal atrophy. On top here you see what's so-called consumption of the epidermis, these nests of atypical melanocytes growing up into the epidermis, this lot of upward growth, big atypical melanocytes, no real maturation, there's no nesting, getting smaller a little bit as you go deeper, but the cytology of these cells is just the same all over. Look down here for any perineural invasion. And these have got mitotic figures, which if you look long enough, you'll find. And these are the cases that I would keep tissue, because as we evolve with genomics, we might find some of these are sensitive to some of these new biologic agents. So if you're going to do stains on something on a case like this, cut unstained slides, because as we evolve in this field, we might need to stain these for the kind of personalized medicine that you need to treat these different melanomas. Because a lot of these antibodies and things in melanomas are not without significant side effects. You can see keratoacanthomas and all kinds of things. And so I think as this field evolves, we are going to start seeing more tailored therapies for these melanomas. And you're going to need tissue to do the studies. So don't waste the tissue. Okay, so the next case is again head and neck somewhere, with maybe scalp with lots and lots of sebaceous glands and hair follicles, a lymph node over here, and then in the dermis, a big nodule, deep dermis in the panniculus actually, with hemorrhage and big atypical cells. With necrosis, you can see areas of necrosis. And look at this when we speak about pleomorphism. Remember those nucleoli I showed you in deep penetrating nevus? They have small nucleoli. These are like owl's eyes. These are big nucleoli, 2 nucleoli in a single nucleus. And look at the variation in size here. Big cells, small cells, shape of the nucleus. Some of these are dying here. These are apoptotic cells. Look at these. Hyperchromatic nuclei. You'll find mitoses. But this is amelanotic. I'm not seeing any pigment. So this is a kind of case you would stain up, and you'd probably do a SOX10 stain and maybe an epithelial stain and maybe a vascular stain to see if it's not an angiosarcoma. And then the history, because this could easily be a recurrent melanoma or in-transit metastasis or a MET, a cutaneous MET. And often you can't sort those out until you know the clinical. So this is would be reported as dermal, for me, dermal and pannicular melanoma if it's stained with SOX10. And then you'd need the history. And this, again, could be a recurrence or a real MET, depending if there was an original melanoma. So this is a very ugly melanoma. Okay, staying in the world of melanoma, this was a nice large biopsy from severely sun-damaged skin. So when you get pigmented lesions, severely sun-damaged skin, you already have your antennae up. And here you can see it's a dermal process, dissecting through the dermal collagen with spindle cells. And there's a lot of atypia here, because here you've got these tiny spindle cells, these bigger hyperchromatic ones. You find mitoses, and often a clue to this diagnosis is if you look deep down, you find clusters of lymphocytes around the nerves and appendageal structures. Here's a little bit of it. See these little nodules of lymphocytes? That's a clue. And this is the dreaded desmoplastic melanoma. And it's pretty easy over here. You see it's got fibrosis with this desmoplastic and an atypical spindle cell proliferation. These are melon A negative and SOX S100 and SOX positive. About 15 to 20% have an intraepidermal component, which helps if you can find it. And the problem with these is if they're on the face and it's a tiny biopsy like this, and there's no intraepidermal, there's a relatively normal dermis with some fibrosis and these dermal spindle cells here, which are quite subtle, people can miss this. And a clue over here is that the solar elastosis is being pushed down. And I think there's been some literature on the so-called umbrella sign. but when you look here, these spindle cells are in this fibrotic area. So if you're thinking of reporting a scar in sun-damaged skin, you better be sure that there was some procedure done there before. And before you do that, if there's no procedure, do an S100 or SOX10 or both to make sure you're not dealing with the top of the spindle cell melanoma, because you often get biopsies out of this size. And this one's kind of easy. Now you see the melanoma dissecting right through into the funiculus. Now, the problem with these cases is stage for stage, they are not worse prognostically than other conventional melanomas, but the best shot you have of clearing this is the first surgery, I think. And so if they misdiagnose and require a second biopsy before the diagnosis happens, you often can have so much scarring there that it becomes really difficult to get the margins. So always be on your lookout for these desmoplastic melanomas. And here, these little nodules of lymphoid cells, as I say, are the clue. I'll show you a few more. So again, these are relatively easy because this one is ulcerated because you've got such a beautiful big biopsy going into the fat. And here you can see these cells. They're not as spindled. This is a more mixed spindled and conventional or epithelioid type melanoma. And this is not as desmoplastic. So this is just an ulcerated melanoma, deep. And these, again, look for perineural and look for intravascular. I've put quite a few of these here because these are really important diagnoses to make. When you look at the low power sun damage on the head and neck somewhere, going deep with these aggregates of lymphoid cells, see them? Right on the first of your mind is desmoplastic melanoma, order the SOX10. And here you can see these spindle cells. They're hyperchromatic. They're pleomorphic, different shapes and sizes. And these ones can often have perineural invasion and don't, as I say, have a dermal component. Now you can see how you can get fooled here if the biopsy is just like this and there's this large mass underneath. And that's why I really think it's important that we have, the pathologist has the clinical size of the lesion, because if this lesion was a 1 centimeter nodule and the biopsy was like this, you can really go down the tubes because there's just melanoma here. And I know with the good dermatologists and well-trained extenders, this doesn't happen, but believe me, in the world of medicine, it does happen. So it's definitely something we want to be aware of. This is a similar one, and we're getting a little bit out of time, so I want to show just a couple more cases. So here is again a nice deep biopsy of a pigmented lesion, and you can see it's got a kind of dumbbell shape at the bottom. And again, you might think of, given on what I've shown you, deep penetrating nevus, a melanoma, desmoplastic melanoma, an epithelioid, a pigmented epithelioid melanocytoma. And when you look on top here, this is also spindled cells, but it doesn't have those hyperchromatic nuclei like we had in the desmoplastic melanoma. They're kind of small nuclei. And I think on top here, people would agree that this starts looking like a blue nevus. These cells that are round are actually just these elongated ones cut on FOSS. And you see the sclerosis and blue nevus-like areas here with the dendrites and the pigment in the dendrites. And then you get more cellular areas down here. And when you look, these cells all look pretty similar, not those big nucleoli that I showed you in melanoma, and associated with melanophages. And these often occur on the buttock or on the feet of youngish patients. And at the bottom, it's got these areas where they're more cellular with the melanophages, and then areas which are more conventional blue nevus-like at the edge. See here? These spindle cells. And this is a cellular blue nevus. So this is one of the mimickers of melanoma. And again, the clue is that there's not real cytologic atypia. You don't see those little lymphoid aggregates. You see this classic dumbbell shape. And again, I usually get these out because they can recur and they go deep, but they are benign lesions and an important diagnosis to make, because if this was called desmoplastic melanoma at this depth, you're going to be into sentinel nodes and adjuvant therapy and all this kind of stuff. Okay, so this one you should recognize, a nodule in the dermis. Get this correct. Looks symmetric. It's nicely out. It's abutting the epidermis, but no real upward growth or good intraepidermal component. Mainly melanophages. Very hard to see the melanocytes here, but these are definitely some melanocytes. These oval nuclei, distinct nucleoli. Nicely rounded bottom here. And this is the pigmented epithelioid melanocytoma. And again, there's a whole evolving genomics in this area of pigmented epithelioid melanocytoma. So while we are nodules in the dermis, I'm going to show this one. It's a little overstained. Looks like, again, head and neck. Dermal proliferation of melanocytes. When you look on high power, these are epithelioid melanocytes. See big nuclei, pink cytoplasm, small nucleoli associated with a little lymphoid infiltrate. Look at these ones here. Each cell looks the same. And this, they like on boards, this is a bapoma. See this field here with these epithelioid melanocytes, pink to purple cytoplasm, enlarged. And these lesions are bapomas. If you do a BAP stain, you find there's loss of BAP. They're markers of patients at risk for melanoma, especially uveal melanoma, but in themselves they are not, they're not malignant. And so this is a beautiful case of a bapoma. I do get them excised again because I think that's kind of where the field is at the moment. So conservative excision, and the patient obviously is monitored and followed for development of melanomas. Now there are a group of BAP deficient lesions that are BAP deficient melanomas. So it can be fairly tricky to decide those. Okay, I just want to show two more because we're kind of getting out of time. This is something we see every day. Shave biopsy, melanocytic lesion, dermal component in the middle, intraepidermal on both sides, small melanocytes with random cytologic atypia, some bridging, the slide's a bit faded, but some bridging of nests, and some concentric eosinophilic fibroplasia. And this, I think here's a better one actually. Here's the bridging of nests, and this is the conventional dysplastic nevus. Over here, you see. And this just shows you some of the problems you have with biopsy, because some of those other things I showed you, if you get a biopsy and it's in this kind of fragmented form, you can really have trouble. And lastly, I want to show this. Or two I'll show lastly. This is a biopsy, and at low power you see normal dermal collagen, and then what looks like fibrosis over here, and above that proliferation, disordered nests and single cells, upward growth. And at the edge of this fibrosis, you see banal little melanocytes like a conventional nevus. And this is the recurrent nevus phenomenon. And you have to be careful of this because these again get overcalled as melanomas. And with these cases, I always call for the history because there's invariably a history of congenital nevus like you see here, which was taken out, and then within usually 6 months there's recurrence. And you can see if you just have a shave of this with no history, it'll get called melanoma. But you can see here the atypical melanocytic proliferation starts and ends just where the scar is. And then as soon as you're away from the scar, there's nothing. So if you have history of benign lesion that's biopsied, some residual congenital or benign nevus, an atypical thing just above the scar, then I think you're safe calling a recurrent nevus. And I guess I can't resist, but here is the last case I'm going to show. Again, a nice shave biopsy, very irregularly nested with some spitz-like features, a cracking artifact, some of the nests pushing up a little bit into the epidermis, almost some bridging over here, so some dysplastic nevus, some spitz, and this is a nevus of special site with all this irregular nesting. So if they're from the breast or popliteal fossa or umbilicus, these are special site nevi. And it's again another one. I think I've got another one here. Here. Another place that we need to know. So I hope this has kind of been interesting. I think the takeaway things are, if you supply your pathologist with the size of the lesion, that's really helpful. If you can do a biopsy that allows to evaluate symmetry and circumscription, that's really helpful. The history of a prior procedure and stuff at that site, that's really helpful. And I think this really shows this team-like effort that's needed to really sort out this morass of melanocytic lesions, where we really depend on the clinicians to supply what is most useful for us to kind of make the most accurate diagnoses. I know it's a time of EMRs, and many of the drop-down menus say rule out atypical melanocytic process, but if you can, I ask you to just add a little bit more to that, and together we can ensure the best of patient care. So thank you, and I will get Ethan to send out that. Thank you very much.